Pratik Kataria. It's always a privilege and honor to have you here. Dr. Pratik Kataria is a dynamic neonatologist. He has done his fellowship in neonatology from Sant Gyaneshwar Medical Education and Research Center, and right now is practicing as a pediatrician, neonatal pediatrician in Jeevan Jyot Hospital, and he's also a panel consultant at Sayadri Super Specialty Hospital and Motherhood Hospital. Welcome, Dr. Pratik. Are we going to Dr. Pratik, or we are going to start with Dr. Brother Ashish?
Yes. So first talk will be by Mr. Ashish Bhaltilak. Yeah. So I'll just introduce Mr. Ashish Bhaltilak. So he's a registered nurse currently working at GMC Nagpur. He's also a mentor for NMG of LACHING and nurse mentor for special care NICU, where they advocate for quality and safety. And he's a BPNI volunteer for breastfeeding. So he's an apt person to speak on this topic. And he has been a breastfeeding advocate and member of various breastfeeding mother support group. So I welcome Mr. Ashish Bhaltilak. So please, you can start with your talk. Thank you so much.
Meanwhile, Brother Ashish said, you can, brother, you can share your screen. We just took one thesis this year for one of the residents, and we were just reviewing the literature. It is very surprising to know that only 40% of the mothers are, exclusively breastfed. 40% of the babies are exclusively breastfed, after the deliveries. Still, there are a lot of issues of, establishing baby-friendly hospital at various levels, and even at 6 months, the ratio is not improving. Hardly 60% babies are actually exclusively breastfed. So I think this topic is extremely, close to the heart for each and every one of us. Each and every one of us has to be very motivated to counsel, should know exact, the component of the counseling, and then we should see that there is, we support the mother so that there is adherence to the lactation and breastfeeding, and, she lactates well, because even partial lactation fare in the current era with all the digital things are extremely common. So, Brother Ashish, are you ready to? Okay, all right. Over to you, Brother Ashish.
I would like to thank NNF for giving me this opportunity, and I would like to thank all the esteemed faculty and the present at this forum. I'd like to start my talk. I'm going to speak on the role of nurse in lactation. Myself, Ashish, from GMCH Aurangabad, working as a nurse at Neonatal NICU, presently pursuing my master's in public health nutrition. Today we are going to see the under 5 data, and the talk contains NFHS data about breastfeeding rate. What does lactation means? The first golden hour. What is breast crawl? Breast milk average size of the stomach of the baby, a newborn. Breastfeeding issues come across. What are hunger cues? Lactate, latching, positioning, holds, hand expression, and milk storage. In study done by Lancet in 2016, says that breastfeeding can save around 823,000 children and 20,000 mothers from death. The same study was done in 2006 around Ghana, published by American Academy of Pediatrics. Also says that early initiation can reduce NNMR by 22%. Seeing to the under 5 child death ratio, key indicators which shows us that the oral hydration, antibiotic, newborn resuscitation, breastfeeding, complementary, all the parameters account to some percentage in the child under 5 child death ratios, out of which breastfeeding contributes to the highest. When we look around the data in India, we can see some indicators. The 56, 57, and 58 number indicators show that in NFHS 5 data and 4 data, there is not much more variation when you see here. So we need to look into this. When we move to the NFHS 5 data of Maharashtra, you can see here, there is not much improvement. This is all about data. When we think about why are we failing, we are a developing countries doing lots of program implementing putting funds in lots of new issues and training. But when we see the DPNI practice study, that only 30% of doctors and nurses receive training of breastfeeding and lactation management. There are mothers who are unskilled in breastfeeding practices. There is minimum support to the mothers during the period of breastfeeding. So this problem accounts a large. What is lactation? We all know. Where does milk come from? Looking at the anatomical structure of this breast, we see that there are 7 to 8 structures which are responsible for the production of milk in the breast. What's triggered lactation? The lactation is triggered in 3 stages, which is known as lactogenesis. The first stage begins around 16 weeks and lasts few days after the birth of the baby. The second stage starts at 2 to 3 days postpartum after giving birth. And the third stage, this describes the rest of the time you lactate. What are the common conditions we come across which affects the ability to lact? There are some conditions like hormonal level fluctuation, some medication, radiations, traumas, breast surgeries, HIV infection, drugs and alcohol. How to maintain a milk production? ये सबसे important वाला चीज है कि मिल्क का लैक्टेशन जो है वो कंटिन्यूस सप्लाई कैसे मेंटेन करना चाहिए, कैसे मेंटेन कर सकते हैं. Hello. Continuing nursing on demand or pumping milk frequently. This is how the reflex goes on. As the mother and the baby, the demand and supply chain is established, the milk production continues. A mother should eat a healthy diet rich in calories, should drink plenty waters to keep her hydrated, should avoid smoking and drink alcohol consumption and drug consumptions. The most important hour starts with the first hour, which is always say that it is a golden hour of lactation. Why it is said that? Because a baby has traveled a long journey and has been into the world and is active for a small duration of time when he enters this world, and after that he gets exhausted and he takes a long sleep. So this hour is very important, where the glycogen storage is used. An early initiation breastfeed can reduce MMR by 22% if we start first hour breastfeeding. Why does it work? It works because there are 14 primitive reflexes in the babies which are active during the stage. The gravity eliminates gap between the mother and body of the baby and chest and the neonatal space available to the neonate. The gravity facilitates easy latch, and the gravity maintains the baby's body in soup. This was a study done in 2008. What is breast crawl? Can it be practiced in cesarean section? Yes. The benefit of it is that a mother undergoes separation, pain, sedation, and that leads to the use of formula for the baby, which ultimately affect the poor hormonal reflux and which decreases the milk supply of the mother. For the babies, suctioning, more throat induced pain and more breathing difficulty, which decreases the sucking reflexes of the baby. Solution to this problem is that we need to practice breast crawl, family-friendly cesarean section, early and prolonged skin-to-skin contact. The average size of the stomach is around 5 to 7 ml on the first day, 22 to 27 ml around second day, and 60 to 81 ml third day. So this is very easy that we can practice a breast crawl. When we see to other mammals, when they get born, they are not being taken by anybody to the mother, or they are not breastfed by their any other relatives, mammary relatives. But we see that mammal moves slowly towards the mother and latches to the mother, and he starts feeding. Same is like breast roll in the humans also. When we delivered the baby on the abdomen, and you can see on the, I will provide you the link for this. When we see that the baby is been delivered on the abdomen and the baby start moving, you can see here in this pic, the baby start moving near to the mother and latches on the nipple and starts his early initiation. And here you can see in Caesarean section, the procedure is being continued. This is a team approach. And when the team decides to do this, they can tackle with other issues arising during the safety and security of the mother and baby too. The magic of breast milk is that the breast milk itself is in different forms, and at different times it changes. That's colostrum, which is the first milk, which is a very important and which is a gold for the baby. And ultimately, in the further days, get mature. You can see 4 milk, hind milk, the day milk, night milk, the preterm baby, the term baby's milk variation, first year milk contents, and the second year milk content differs. Single mother, single born, and twins amount differ. During our practice, we come across many breastfeeding problems. Commonly, we can see sore nipple, breast engorgement, plugged milk duct, low milk supply, abundant supply of milk. This is what we come across, and this can be done beautifully. So for example, for breast engorgement, you can have cold and hot compressions and help mother to release her pain by slowly massaging, helping her to not get more panic, and help her to, we will see in the further slides that how to latch, how to attach, how to position, which decreases the incidence of breast engorgement. Sore nipples is quite tender and painful. Here also you can apply compressions to reduce it. Blood milk ducts can be released by proper techniques of massaging, and baby can be helped to breastfeed. Low milk supply is always a issue we come across. And we can see that when God gives a baby to a mother, he gives a feed for her also. Means the baby can feed completely on her mother. It is not as such that the mother and baby, we come many times we come across that मुझे दूध ही नहीं आ रहा है, मुझे दूध ही नहीं आ रहा है. This problems is quite common in various NICUs and NICUs around. But when we counsel mother, proper latch and attachment and position is there. There are many a times we see that 80 to 90% issue has been solved. An abundant milk supply is also a condition where you can collect the extra milk, or you can just press the other side to stop the milk flow. No need to do any additional things for it. When to best feed a baby? We come across the baby and we see that we feed the baby mostly in this stage, that is crying stage, third stage. If you see that there are early cues, there are mid cues and late cues. What are early cues? That staring, mouth opening, turning aside, and this way baby tells that उसे भूख लगी है. And we see that in the second stage that baby get more hunger, gets more really irritating. And in the third stage, we see that it gets crying. And this time when it gets crying and you try to latch or attach the baby, he will not take milk. So first you need to calm, make him skin to skin and cuddle him, and then you can start feeding. What is latching? You can see the 4 steps in latching. This is how the baby's chin is stretched here. This is, and the upper area is open, and this is how the good latch. Let's see one by one. The first step, you can hold the breast in the sandwich like form, nose to be touched to the nipple. Here you can see the wide opening of the mouth. The chin should be touch here. This is how the lower alveolar goes into the mouth. And this is how the ideal latch is. The baby's nose is open, he can breathe properly, he has no issue. And this is how the smooth flow of milk goes. Signs of good latch are like more alveoli is visible, mouth is wide open, lower lips turn out, chin touches the breast. The mother has no pain. This is how it goes: nose, alveoli, lips, and chin. How to widen mouth? How to using sandwich hold? It's how you need to squeeze the breast, hit it to the nose, and insert deeply. How can you ensure that that good milk supply is being transferred to the baby? बहुत सी बार हम सुनते हैं कि मेरा बच्चा अच्छा पी रहा नहीं है, उसका पेट भर रहा है. But how to know that when you encounter with such mothers and such issues, you need to ask mother few questions like how many times the baby has been passing urine in 24 hours, whether he is feeding or he's sleeping well, he's active, and whether he's putting weight per week 127 to 250 grams and 750 to 1.2 kg per month. This is how you can initially assess the mother and ask issues regarding feeding. Some errors in latching is as such. You can see in this photo that the baby is latched only just to the nipple and just is sucking to the nipple. So this is how it is a poor latching, which decreases the baby's weight and is poorly feeding. Next, we'll move to the positions. We'll see here position of the mother and baby. In this pics, you can see that this is a position where most mothers feed their babies, which is ideally a wrong position to sit or to encounter during feeding. This is how a mother and baby should be in feeding stage. The mother should be straight, sitting upright, use pillows to support her back, lap, feet. This is mostly when we encounter in communities that the mothers are feeding, maybe due to any social issues or privacy issues, but this is wrong feeding technique which should not be used. You can support your legs, sit properly, comfortably. How should be baby's position? Mother's arm should be supported by pillows, fully turned towards the mother. The baby should be fully turned to the mother. Head, neck, trunk, buttocks should be in a line, supported by mother's arm and not by pillows. Here you can see this is a twist position, which is a wrong position. In this position, the baby's mouth or the head is towards one direction and the trunk and body is towards the another direction. This is a poor feeding technique. This is how it should be. The head, the trunk should be the same line, the abdomen touching to the mother's abdomen and the baby in properly folded. Few positions will come across are cross cradle. You can see here this hand. Can you see my pointer? Hello? Hello?
Yeah, carry on.
Yeah, we can see your pointer.
Okay. This is how cross cradle position is. No hands in the way, better head control, and the babies are being holded in such a position. This is how it should be. The hand and this baby is folded here, one finger below his ears, this head is fixed, and this hand and the baby is in straight alignment. This is a football hold, no hands in the way, better head control. Baby, if baby is refusing one breast, you can take it to the another. This is how, if you have seen football matches, you can see that the bowler holds the ball in these arms. Is such how the baby is being held here. You can use from both the side. Mostly, this position is a sideline position, which is being preferred during nighttime or the sleeping hours, where episiotomy or Caesarean pain is there. You can be feeding babies in such a way. This position can be used during the time of delivery also. The baby's baby's legs is towards the head of the mother, so that there is no issue during any surgical procedure undergoing Caesarean section or any other procedures going during the time of delivery, and the baby is held from the upside. A nurse can try this intervention, which is very flexible and doable. These are few pics. It's a backlit position which is modified, which has been used as during Caesarean pain, episiotomy pain during night time, with large breast, with mother and baby is comfortable. With the gravity, baby latches to the breast. Few disadvantages: hands in the way neck get twisted during cradle. Few holds, C hold, which is like sandwich. You need to hold the breast in such a way that it should hold it at the backward, so that the baby attaches here properly. It should not be holded in the front here. Not should be pinched and put into the baby's mouth. This is not you should hold. You should hold the breast in such a way that when you press it here, the milk flows from the duct. We have seen the breast anatomy. The milk ducts flow. The milk is being collected at the nipple. If you press here, the milk won't come out. This is a C hold and this is a U hold. You can see here the mother holding scissor hold. Always say no to the formulas. If this is formula, I would like to say that this is breast milk. Always use hand expression techniques, which is very useful and convenient technique, which increases good supply for a long duration of time. Don't go with manual automatic expression or pumps. Start with hand expression. Always counsel mothers to hand express, which increases her efficiency and her feeding confidence. First, you need to counsel her that you need to massage in this rotating manner slowly around the breast, stroke upside down, slightly shake right to left, and this way to push to the chest wall. When you push in this direction, the milk ducts, sacs filled with milk, are being compressed and the milk passes to the nipple opening. Some rolls and then finally finish roll. If you find any difficulty with expression, with hand expression, very painful, or the mother who is unable to hand express due to some medical issues or any such pain, you can use breast pumps. Milk can be stored at 4 to 6 hours and ideally room temperature, 24 hours in ice box, 3 to 6 months in the upper compartment of the fridge, that is refrigerator and the fridge upper freezer, and the lower side you can store it for 3 to 5 days, and defroze it you can for 1 year. This is how tube feeding is also being practiced. No to bottle feeding. I've referred some global health media, YouTube
Brother, 5 minutes to wind up, huh?
You can refer global health media, where you can encounter with lots of learning, which is in various languages. A good, I would recommend, is health spoken tutorials by Dr. Rupa Dalal, mostly in most of the Indian language, Hindi, Marathi, and local dialects. You can also refer to Jessica Barton videos of breastfeeding and Dr. Taru Jindal's breastfeeding playlist on YouTube. I would like to acknowledge my mentor, Dr. Taru Jindal, who is IBCLC's, Dr. L.S. Deshmukh sir, HOD Neonatology, and my team at GMCH Aurangabad, all families of breastfeeding mothers with whom I have encountered at JMCH. And I would, at the outset, I would like to thank NNF Maharashtra for providing me this opportunity and all the breastfeeding advocate listening to this presentation. I would like to end my talk with, every child is born with some uniqueness. So don't compare his or her uniqueness with other children. Because of his or her difference, find the unique qualities of your child and accept them as they are. Thank you.
Yeah, thank you, Mr. Ashish, for that excellent presentation. Rahul Verma sir, any pearls of wisdom on breastfeeding?
So I think Ashish has done a great job of initiation to the end. I have only one thing to put in, and I think this is based on 2 consecutive studies that we have done on lactation, and that is counseling. I think, as a nurse, doesn't have to be a formal counselor, but as a nurse, I think if we start antenatal counseling and continue it across intrapartum and then continue postnatally, I suspect that we will have more mothers who are much more comfortable in initiating and maintaining breastfeeding.
Yeah, true.
I think that becomes a very important point. So I think counseling, whether it is done by the nurse, who's probably the best person, since they are in contact day in, day out with the mother, and then whether if you have an official lactation counselor or a doctor, the obstetrician, the pediatrician, whoever it is. But I think that becomes quite a significant situation for us. And I think we should promote that.
Yeah, that's a very valid point, sir. Very valid point. So it will be really important if they can understand the entire procedure of breastfeeding and what they're going to face in future through antenatal counseling and as well as postnatal counseling. Okay, so now we'll continue with the next speaker, which is Dr. Pratik Kataria. So he'll be talking about pain management in newborns who are admitted to the NICU. So I welcome Dr. Pratik.
Good evening, everyone.
Yeah.
Good evening, sirs. Let me just start by sharing my screen. Is my screen visible to everyone?
Yeah, just make it like presentation.
Yeah, just a second. Yeah. So good evening, everyone. I'm Dr. Pratik Kataria, practicing pediatrician and neonatologist in the city of Pune. I would first of all like to congratulate Mr. Ashish Baltilak for such a wonderful presentation on one of the most pertinent topics in neonatology. He has done a great job with the presentation. Also, I'd like to thank all the respected seniors and colleagues for providing me with this opportunity to deliver a talk for the nurses, because as we know, nurses are one of the most key factors in the smooth functioning of the NICU. They are like the backbone of the NICU, and without them, the success rates of NICU start dropping drastically. So I'm very privileged to take a topic which I think in which nurses play a very vital role. So the topic for today is neonatal pain management. So what is pain? So pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. We must evaluate, recognize, prevent, and manage pain in the NICUs. Right from the first point, evaluation of pain, the nurses play a very important role in this. Why? Because in their daily rounds, the nurses are the ones that are spending the maximum amount of time in each and every neonate in the nursery. So every time they take their rounds, it is very important that they evaluate whether a child is in pain. They recognize the signs and symptoms of pain in neonates, and as far as possible, they prevent the pain, and if not, manage the pain. Like with everything in medicine, prevention is better than cure, and the same goes for pain. Now, the next question is, why is pain management so important in the NICUs? Newborns are more sensitive to pain as compared to older children and adults. And like Dr. Ashish Dhongre rightly mentioned at the outset, almost around 14 procedures which are painful are performed on each and every neonate in the NICU on a daily basis. So if they can perceive pain, they can feel pain, and they perceive it more than the older children and adults, it is very important that we prevent pain and after that manage pain in the NICU. Most NICU procedures result in undesirable stress response in neonates. Poor pain management during the neonatal period leads to permanent changes in brain processing and maladaptive behavior later on. If the pain management is done well, it has shown to significantly improve recovery time, it improves the healing, and it can also prevent development of chronic pain. These are the basic reasons why we should be very, focused on managing pain in neonates in the NICU. How does one assess pain in the NICUs? There are a lot of pain scales that are available and that are used in different neonatal ICUs across the world. I have mentioned a couple of them over here. First one is for the assessment of acute pain. This is the premature infant pain profile, PIPP. And the second one here is used for the assessment of prolonged pain. This is the neonatal pain agitation and sedation scale, NPAS. I would not like to go in detail about these pain scales because this is a vast topic in itself. But one point I'd like to make to the nurses who are listening to this lecture is that try to use these pain scales in the NICU during your regular rounds. These are exhaustive pain scales. A lot of factors need to be considered when you're using these pain scales. But once you start using them on a daily basis, on a weekly basis during your rounds, you get used to them. And they are very good to determine how much pain the neonate is in actually. Neonates are very unlike older children because they obviously do not express how much pain they are in. The subtle signs of pain may range from just a decrease in heart rate to a little bit of wincing. So using these pain scales will help you a lot in actually determining whether the babies you are taking care of are in severe pain or not. So now that we have talked about pain and how you are supposed to assess it, we will proceed to what you need to do to manage pain in the NICU. Now, for pain management, there are two types of measures that can be taken. One set of measures are the non-pharmacological measures, and the other set are obviously medicines, which are the pharmacological measures. So first off, we will start with the non-pharmacological measures. In that comes NNS, which is non-nutritive sucking. It is done above 28 weeks of gestation and in those who have developed a suck response. I'll just go through the list first and then we will discuss each and every point in a little bit of detail. Breastfeeding, which we all know is very helpful. Then there is something called as facilitated tuck, containment hold or swaddling. Then kangaroo mother care, minimal handling and music therapy. So let's start with non-nutritive sucking. So what is non-nutritive sucking? Sucking on an empty breast nipple or a pacifier or a gloved finger dipped in a glucose solution. This is non-nutritive sucking. So a practical tip to all the nurses working in the NICU, use this when you are doing small things like heel pricks or doing, sample collection, venipunctures. Use this. I mean, try to promote non-nutritive sucking. Maybe you can combine it with using glucose or sucrose or something like that. So it is a very helpful and effective method. The next one is facilitated tuck. As you can see in this picture, the newborn seems to be very calm and relaxed. You can see the parents' hands, touching the newborn in a very specific way. So what is a facilitated tuck? A parent or a nurse holds the neonate in a side-lying position and in a fetal flex type position. What that means is either the baby should be on a left lateral or a right lateral side. The parent's hands should be holding the neonate in such a way that one hand is holding the lower limbs and the lower limbs are flexed and close to the trunk, and the other hand is petting the baby's head, to be more specific. Okay. Containment hold. This is something very similar to a facilitated tuck. This is a technique in which the neonate is positioned to promote a sense of control and security. Again, you use two hands to hold the baby securely. One hand on the baby's head, one hand on the baby's feet. Okay. In a containment hold, you can use rolls or nests and you can position them to specifically around the baby in such a way that the baby feels like the baby is in a womb. The baby feels secure, the baby feels in control, and baby feels comfortable. Swaddling. Now, this is something all NICU nurses are experts at. What is swaddling? It is wrapping a neonate in a cloth or a blanket with their arms and legs tucked in to make them feel secure. So every neonatal nurse is an expert at swaddling. They know when it's to be done. Every time a baby cries, what most nurses do is they try to swaddle the kid, or they do a facilitated tuck, or they do a containment hold, and you can immediately see the response. The crying time decreases, the baby's heart rate goes down, the babies feel more comfortable, and that's the idea. I mean, as long as the baby feels more comfortable, the baby will feel less and less pain. Next is KMC, or kangaroo mother care. I believe already a lecture on kangaroo mother care has been taken in detail, but I'd just like to touch upon a few basic points regarding KMC. So it is defined as skin-to-skin contact, most commonly instituted shortly after birth. It is used for warmth and bonding, mostly in developing countries. It is known to decrease morbidity and mortality, especially in preemies or preterm neonates. KMC is known to decrease crying time, it improves pain scores, and it decreases stress in preterm neonates. Music therapy. This is something very unique. This is not practiced in a lot of NICUs in our country, but I believe that this is very effective. There are two ways of going about it. One is that you let some soft music play in the background in the NICU on speakers, on a central speaker, at low volumes, very low volumes. Okay. And the other thing, which is more common in the Indian scenario, is a mother singing in a soft voice, which helps in pacifying a neonate in pain. So this is more commonly seen, that you see that a mother is sitting on the KMC chair, is providing KMC, and you hear that in a very soft voice, she is singing to her child. Do not discourage this behavior. I have seen a few nurses tell the mother to not sing because it might disturb the other kids, it might disturb the other parents. But on the contrary, you should encourage such practices. You should make sure that you are assisting the mother, enabling the mother in doing these developmentally supportive NICU cares. Okay. What music therapy does is it improves vital signs, it improves feeding, and it improves sleep. So you see that when a mother is providing KMC, mother is singing to a child, the child is sleeping peacefully. And after some time, then you see that the mother is also going off to sleep, because bond has developed between the mother and the child. Both are very calm, they are collected, and they are very happy. So promote these practices. So now we move on to the next topic, which is pharmacological agents. Multiple pharmacological agents are there. There are a few which have not been mentioned in this list, but I'll just like to touch upon these few basic ones. Sucrose, paracetamol and NSAIDs, opioids, benzodiazepines, barbiturates, and local anesthetics. So let's start with sucrose. So the recommended concentration for sucrose is around 24%. You use this sucrose orally, it reduces procedural pain, and it works by mediating the endogenous opioid release. So basically what you're doing is you're instigating the body to release a little bit of opioid from the body itself endogenously, and it works well. Sucrose is used to provide mild procedural pain relief. Okay, it is not used in procedures which give a lot of severe pain to the child. So remember that. Sucrose can be used along with non-nutritive sucking, like I mentioned. It works wonderfully. Next is paracetamol. Everyone knows about paracetamol or acetaminophen. It works by inhibiting the COX enzyme in the brain. Again, this again is used for mild procedural pain. It is used during immunizations. It is used during ROP screening. It is sometimes used in conjunction with other analgesics during circumcisions. Important point to remember here is in children with sepsis, in neonates with sepsis, if their liver or renal functions are impaired, you should be very cautious while using paracetamol. Okay. Next is opioid, fentanyl. Now, fentanyl is, again, fentanyl drips are used a lot in the NICU, in which neonate is in severe pain or for sedation or analgesia. Okay, it is an opioid analgesic. It provides rapid analgesia. It maintains hemodynamic stability, and it prevents pain-induced increase in pulmonary vascular resistance. So all the NICU nurses who have handled babies on ventilators, you must have used fentanyl at 1 microgram per kg per hour. We are using fentanyl because we do not want the child to fight the ventilator, like we say, because fighting against the ventilator, a very active child not synchronizing with the ventilator is a bad scenario because it increases the pulmonary vascular resistance. I have made this slide specifically for the nurses because making fentanyl, again, is a very specific thing. You need specific values, you need specific directions for that. So this slide would come in very handy for all the nurses. So the concentration of the syringe is 0.1 mg per kg of fentanyl diluted in 25 ml of any compatible diluent. When you make this infusion and you start the infusion rate at 1 ml per hour, it delivers 4 microgram per kg per hour of fentanyl. Now, the range of infusion for fentanyl is 1 to 5 microgram per kg per hour. Ideally, you should be starting fentanyl at minimum dose, which is 1 microgram per kg per hour. And if you feel that the child is not getting sedated, child is still in severe pain, still agitated, still fighting the ventilator, then you slowly increase the dose. All right. Okay, next group of drugs is benzodiazepines. Now, these drugs are less used for pain relief and more during seizure control. Okay, so midazolam and lorazepam are the most commonly used group of benzodiazepines. Even if you give me a choice between the two of them, I would prefer lorazepam because it has less side effects like respiratory depression. It can be used for mild sedation during procedures. So this is a very nice picture of an NICU. What I'm trying to explain everyone by showing this picture is that we need to optimize the neonatal environment. So what that means in simple words is try to make the NICU as close as possible to the mother's womb. The experience of the neonate should be as close as possible. I mean, I'm sure you cannot make it 100% like what God has provided, but our job should be to make it as close as possible to the mother's womb. So now the problem with that is the busy NICU, the model neonatal intensive care units are very noisy. It's a very stressful environment, a lot of emergencies happening, a lot of alarms blaring, a lot of telephones ringing, a lot of bright artificial light. We need to curb all those down and get to a place where the environment is dark, muffled, secure, like the womb. Okay. There is now an increasing evidence that providing a nurturing, peaceful environment and avoiding noxious stimuli like pain, excessive noise, and interruption of sleep cycle can lead to an improved developmental outcome. But at the same time, we must remember that we should have at least some degree of stimulation, because totally removing all the stimuli is also not good for the neonate. So this is a wonderful table which tells us about all the adverse stimuli that are present in the NICUs and what are the strategies to reduce their harmful effects. So let's start with the first one, which is noise. So The noise limit in the NICU should be below 65 decibels. Background noise should be below 45 decibels. How do you check that? If possible, install sound monitors in the NICU, and if the sound monitors are there in the NICU, make sure that you monitor them. All right. You have to respond to the alarms promptly, and you have to reduce the volume of the alarms as soon as you go to the child. Okay. So first thing you do is you assess the clinical condition of the child, why the alarm is blaring, you reduce the volume, okay, and you respond promptly. What respond promptly means is, obviously, that if an alarm is sounding, it is an emergency, a nurse should attend to that child immediately, right? And the second thing, you reduce the volume, because the noxious stimuli of sound will cause problems for the child. Whenever you enter or exit the NICU, do not bang the doors. Whenever you close or open the doors of the incubators, make sure that you do a soft closing. Okay, you do not disturb the child. CPAP circuits, as everyone knows, are very noisy. During your rounds, this is specifically to all the nurses handling, ventilated or CPAP babies or NIV babies. Make sure that the expiratory piping of the CPAP is outside the incubator. All right. You fit the baby with protective earmuffs during MRI scans. This is also one very important thing you can do to reduce noise pollution in the NICU. Now, the next adverse stimulus is the light. Try to have periods during the day and at night when the lighting is dim. Again, you try to get to the environment which was present in the mother's womb. So again, the lighting should be dim. Cover the baby's eyes when switching on an examination light to avoid startling. As far as possible, try to use a point source of light so that the light does not shine on the entire baby and the baby's circadian rhythm is not disturbed. Using protective eye shades during phototherapy, I'm sure everyone knows what this is. Some visible natural daylight is healthy for staff and parents. So, like I mentioned in the previous slide as well, we have to remove the noxious stimuli, but at the same time, we have to make sure that little bit of stimulus is going to the child. Complete absence of light stimulus is also not a good thing. Okay. Pain. So we have discussed in detail about pain. We try to provide prophylactic analgesia for procedural pain. We should provide discomfort from mechanical ventilation by giving sedation if needed. So again, like we discussed, sedate the child if the child is fighting the ventilator. Okay. Painful disorders like long bone fractures, osteomyelitis, necrotizing enterocolitis require adequate analgesia. Smell. Ensure that the incubators are cleaned regularly and water, clothes, and bedding are changed daily. Avoid noxious chemicals, that is powerful cleaning agents, when the baby is very close to the chemical. All right. Thermoregulation. Thermoregulation is basically temperature control. Ensure that there are no drafts near the baby. Use incubators where appropriate. No drafts near the baby means generally in most NICUs, there are no fans that are used because a draft of air near the baby will suddenly cause hypothermia. So make sure that the windows are not open in the NICU and the baby is not very close to the window. Okay, close incubator doors and monitor temperature continuously if the baby is in servo-controlled environment. Okay. Overstimulation. Normally, newborns sleep for most hours of the day, sometimes maybe 18 or 19 hours in a day. Okay, sick infants and preterm infants must be allowed to rest and achieve a normal sleep-wake pattern. So for that, again, we should not disturb them. We should try to cluster as many procedures as possible at one go so that we do not disturb them every 15-20 minutes, every half an hour, every 1 hour. And again, light cycling has to be done. Okay. They should be clustered together, like I said. It is the role of the neonatal nurse to enforce this. This is the most important point. Nurses are the ones who are spending the maximum amount of time with the newborns. I'm saying this again and again. They are around the incubators, around the warmers the entire time, monitoring all the kids, not just the very sick kids, even the children that are just admitted for phototherapy. So it is very important that you look at all these factors as well. I know the NICU is a very busy place, and to manage pain by doing all these non-pharmacological measures can sometimes become practically impossible. But remember that if you reduce pain in the children that you are treating, they will have excellent neurodevelopmental outcomes. They will not develop chronic pain, and all these things give you more satisfaction. So intact care, intact survival will be better. All right. So a small slide regarding procedural pain and analgesia. So blood sampling, all the nurses are doing blood sampling. They are doing heel pricks to check BSLs. Remember that a heel prick is more painful than a blood sample. I see a lot of NICU nurses which are new, which are freshers. What they do is they do a heel prick and they try to collect a CBC. Please remember that that is not the right way to collect a CBC sample. Two things it does is, firstly, sometimes, most probably, it will lead to you not getting an adequate volume of sample. And secondly, read this line again, venipuncture is less painful than heel prick sampling. Okay, always choose the appropriate method. Topical anesthetic can be used in older neonates. You can use oral sucrose just before the procedure or NMS. Okay. Next procedure is lumbar puncture. Again, for lumbar puncture, you can use a topical anesthetic for 30 minutes. You can sometimes use midazolam at a very low dose or lorazepam at a very low dose to sedate the child so that you do not get a traumatic tap. Chest drain insertion. Local anesthetic, again, needs to be used. It needs to be used along the tract. UVC, UAC, you do not generally require analgesia for UVC, UAC, but make sure that towards the end of the procedure, when you are doing the retaining stitches, make sure that they go through the Wharton's jelly and not through the skin. Like I already mentioned, ROP screening can be tackled very well with oral sucrose, or you can give glucose, dextrose. ROP laser treatment sometimes requires general anesthetic or an opiate infusion. Venous or arterial cannulation like PICC line, again, topical anesthetic or oral glucose. Okay, I have jotted down these 5 points which are very important for nurses to remember. Okay, during your daily rounds, try to do routine assessments to detect neonatal pain. Very important thing. So carry your pain scales with you. And if you're seeing 3 or 4 babies, it might take a little more time for you, but try to perform these routine assessments and try to detect neonatal pain. Because unless you detect it, you will not be able to treat it. And if you do not treat it, you are basically saving the child's life, but you are leading them down a path where the neurodevelopmental outcomes might be poor. Okay, next, reduce the number of painful procedures. Now, sometimes it is not practically feasible to do this, but try to minimize the number of painful procedures that a child undergoes. By that, what we are trying to say as neonatologists is that try to, for example, do the blood sampling at one go, in one prick. Try to do it in the morning time and make sure that the blood sampling or the tests that are to be done have been discussed with the neonatologist or the senior nurse, and all of them are sent at one go. So this is one of the examples where you decrease the number of painful procedures. Next, prevent or treat acute pain from bedside invasive procedures. This, I think, needs no explanation. The next one is anticipate and treat post-operative pain after surgical procedures. So after any surgical procedures, make sure that you ask the treating neonatologist if any pain management needs to be done specifically, any opioid infusion needs to be started, maybe oral paracetamol is to be given, just sucrose, any of those. Okay. And the last point, avoid prolonged or repetitive pain stress during NICU care. Now, again, this is very subjective. If an expert is performing any procedure, the stress or the pain will not be prolonged. He will do the procedure, for example, a PICC line at one go. Sometimes I understand that it's not possible, but as far as possible, a NICU or a neonatal nursery is a very delicate unit, and it is very important that experts perform most of the procedures in the NICU. So with that, I have come to the end of my presentation. I hope this presentation was helpful to all the nurses who are listening. And I would also like to say thank you to Maharashtra State NNF for providing me with this wonderful opportunity. It has really been a privilege to teach the NICU nurses.
Yes, thank you, Dr. Pratik. It was a brilliant presentation.
Thank you,
and
sir.
such an important topic, and always the pain management gets sidelined in our NICU when we are too much involved in controlling sepsis and managing sepsis.
Very true.
Yeah. Dr. Verma, sir, any take-home messages from your side?
So I think it was a very comprehensive talk on neonatal pain management. And unfortunately for us, which we don't seem to always realize, is that the pain point is introduced from the time you intubate the baby in the labor ward without giving any sedation or analgesia. Also, the second part is that I think we should not confuse pain relief from sedation. So when we use things like fentanyl or Dexmed, they are actually sedatives. Benzodiazepines, all of them are sedatives. So pain relief still carries an important aspect, and I think that is very important to remember. So simple paracetamol, 24% glucose gel or solution, swaddling the baby, cuddling the baby, breastfeeding the baby during simple procedures. It's also interesting to understand that thoroughly painful procedures, there are almost 14 to 16 procedures done in the first 2 weeks of a baby's life. And if you have a preterm baby who stays with us for over 90 days, there are almost 400 procedures which contribute to pain, whether in a small way or in a major way. So all of these things have to be kept in mind. Lastly, we depend on a lot of subjective scores for pain. We do remember that increase in heart rate, changes in blood pressure, changes in pulse oximeter are also very good indicators for pain. Of course, we don't do cortisol levels and all the other biochemical markers, which are much more direct correlators of stress and pain. But I think we just need to remember that whatever we do, we need to constantly repeat these scores so that we become much more accurate and we can correlate very well with the neonatal pain. And I think the nurses, I think, have a very, very important role to play in this. As you rightly put in, Dr. Pratik, that, softening the lights, comforting a baby, swaddling a baby, all of these are very, very basic but very important ways of trying to reduce the pain stimulus in such babies. Yeah.
Thank you so much, sir. Thank you.
Thank you so much, sir.
Yeah, so pain management should receive like a prime importance in every unit, and it should not be sidelined. So I think every unit, if not practicing, they should realize that the pain is real in babies, and pain management is an important thing. So you should have a guidelines. You should have some protocols in place, and keep on regularly auditing these protocols. So you know where you are lacking or where you are digressing. And then you should have a protocol like stepwise how you will manage what kind of pain it is and how will you manage that. So if every unit has that kind of policy, I think it will make a remarkable change in pain management in the units. So with this, I'd like to thank both the speakers as well as our experts, Dr. Rahul Verma sir and Dr. Jaisal and Dr. Rishikesh Thakre for the support. So before I wrap up, the next session will be on the 8th of July, and that time we'll be talking about patient safety and feeding of premature babies. What is the optimum technique of feeding premature babies? So I would like to thank all the viewers for joining in, and hope they had a good educational session. Thank you so much. Thank you all.
Thank you very much for inviting me, and all the best to you all. Bye.
Thank you, sir. Thank you.
Thank you.
Yes, sir. I think